every 2 weeks, a visit every 2 weeks. And in the inclusion criteria, you had to have haircuts at least once a month to be included in the study. Which is really a very unusual inclusion criteria when you think about it. The number of times that you have a haircut per month. All right, so the results. In the intervention group, we saw a large reduction in systolic blood pressure from 152 to 125. Smaller reduction in the control group, 154 to 145. The main outcome measure was this reduction, but also looking at the percentage of patients who met certain levels of goals. And less than 140 or 90, this is after 6 months, almost 90% in the intervention group, or less than 140 over 90 compared to 32% in the control group. That's a big difference. And if we look at the more stringent, more recent criteria, less than 130 over 80, 64% in the intervention group met that criteria, and 12% in the control group. I've done a lot of studies, read a lot of studies. These are big. These are like, to me, I guess, I'll let you guys make your decision, but I think these are big results.
Can I interrupt you for just a moment, Jan? Dr. Wanacott, I'm sorry to put you on the spot, but you were saying on one of our planning calls a few weeks ago, and I'm catching you with your mouth full, but so I'll just say that for each drop of 10 points in your systolic blood pressure, the number of events, cardiovascular events, falls radically. If you want to elaborate, great. But otherwise, I just want to point out the significance of those numbers in terms of patient outcomes are really, really important.
So I was speaking specifically of cerebral vascular events, but that was a way to really help our patients know that this is significant when most would say, well, it's at 140 over 90, that's just fine. And that may have been, 30 years ago what we said. But now being able to use those kinds of numbers to realize that, if your systolic is bumping up 20 points from 120, then you're doubling your risk there. So, and when you start mentioning that to patients, then they start, that means something when you say you're twice as at risk, you're double as much. So yeah, that makes a big difference.
Thank you.
So the other thing to point out here is in the intervention group, as you would expect, the number of medications was greater than the control, which was the intent. It was an intensification of the medication therapy. And this is just a breakdown of the types of drugs they were on, which it was different, but it was driven by the protocol that the pharmacist was following. So what made the intervention work? It really is multifaceted. It's not the pharmacist did have special training from cardiologists to be in the program. Convenient access, right? These patients were going to the barbershop to begin with. It was a really trusted place they could go to get information and monitor their blood pressure. More intensive medication therapy was clearly the lower blood pressure targets. They were trying to get to the 130 on over 80. Consistent patronage that over 10 years, these patients have been going to the barbershops. And then again, that trust that was the endorsement by the barbers. So I think, from my perspective, it is certainly an area that we should continue to try to engage patients. One thing that Susan and Ivey pointed out to me last night while we were going through our slides, is this is only men. So it's not everybody, but there may be other places like this, to really engage patients in a much more intimate, in an area where they have a trust. They've already have a trust. And I would say that community pharmacies are part of that, is a possibility. Yes?
So 2 questions, actually. So the participants assumed before they went into the program had persistently elevated blood pressures. It wasn't just a one-time thing, or was that really considered?
So what they did is they measured the blood pressure. They did an initial screening blood pressure, and then I think they had them come back a day or so before. And then they did 5 blood
There
pressures.
you go.
So they did do multiple,
Okay.
and you had to meet multiple criteria.
And it just, it dawns on me that this environment, well, those are probably pretty real blood pressures, especially if they have to come in and sit down and relax. You eliminate the whole concept of white coat syndrome.
Yeah.
And so, to me, the value proposition of a study like that just goes right through the roof. Because our hypertension program, it was relying on blood pressures, patients that just walked into a provider's office, climbed up on the table, they're still breathing hard from trying to get there. You've got to do something with the blood pressure, so that's pretty cool there.
That's on, yes.
I'm not sure if you were able to speak to this, but I'm just curious, it seems like the patients themselves were very amenable to this, but it seems like I could see some people saying, I don't want my doctor in my barber shop, I like it being an intrusive thing, but it's well received in general.
From what I can tell from the inclusion-exclusion criteria and the number of people that were excluded and their reasons, I think it was well received. And there was nothing mentioning that there was a huge backlash or whatever. I don't know if either one of you guys know more about the study individually.
Yeah, we'll have to look and see how many people were approached versus how many people signed up for the program. That would give you an idea of how many people opted in for the program.
And I did sort of look at that where they're in the paper, and it didn't seem like it was unusual. Yes?
What was the incentive for the actual barber shop?
That's, as far as I know, there was no monetary incentive given. I'm actually going back through the article in my head, most of you guys remember. I think it was their patients. I'm speculating. I don't know that there was a specific incentive offered to the barber shop. I don't recall that.
Where did the $85 go to?
The $25.
Or 25?
patient.
To the
To the
patient.
patient, and that was supposed to be to help with generic cost of the medications and or transportation. Yes. And then there was a free haircut, so I guess it was patronage. It could be somewhat from
And one free haircut.
every month.
Every month,
Every
a
month,
free haircut. Okay.
So I think patronage was it. Yes.
Who paid the barber for that haircut?
I think the study did, or what?
Yeah.
It was from the study.
Yeah.
So, I mean, some incentive, the barber has his clients come in and they get free haircuts and he gets paid for it. And there was a small amount of money, $25 to encourage transportation participation.
Yeah. So it was business. Right here.
I think there are several limitations to the study. I think number one is obviously the black male patrons.
Sure.
Number two is the cluster randomization process. Number three is the short-term follow-up of only 6 months. So, I mean, all the clinical outcomes that we're looking at, whether it's cardiovascular or neurological, are more longer term.
Mm-hmm.
The other thing was that, as you highlighted over there with the lower blood pressure target, based on JNC 7 guidelines was when the barbershop trial was initially initiated. It was a 140/90. Obviously, there are various guidelines for us to look at, whether it's hypertension, whether it is in the high-bet trial looking at geriatric population, geriatric patients. So I think that here there was an indication for them to shoot lower, and hence they performed better, possibly as a confounder of ascertainment bias, because of the fact that there were more patients in the non-control group and targeted lower blood pressure that was ascertained for the JNC 7 guidelines at that stage as well. So there are numerous limitations, but the thing that I think we can still take away is that hypertension or even management of a patient requires a village, and it does need active involvement of whether it is the barber to cut my hair when I'm losing all mine, or whether it needs a PharmD or an active intervention to take place to kind of give you an alert on your phone or whatever.
Yeah, no, I agree. There certainly are limitations to the study. And the 12-month follow-up we'll see. That's ongoing right now. You're right, this is only 6 months. I'll take one more question. Yes,
How was the cost of the home blood pressure telemonitors covered?
There wasn't home blood pressure in this one. The blood pressure was taken at the barber shop.
Okay.
Yeah, so that was actually at the barber shop, and that was part of the study. Okay, I'm gonna move us on from that. We may come back to that later in more questions. Just the next steps that are ongoing with that, there's collaboration with the LA County Department of Public Health, Cedars-Sinai, and Steve Chen is USC School of Pharmacy. They're working on furthering this concept. I think Susan's going to talk more at the end about Senate Bill 1264, which is looking at Medi-Cal payment for hypertension medication management by qualified pharmacists, similar concept. Expanding the availability of comprehensive medication management, which this was an example of in hypertension, through community pharmacies, and that's something I want to talk to you about next. And then educating everyone about the value of pharmacists, which is part of what we're doing here. Now I'm going to move you forward to thinking about, that was for barbershops. Now let's think about community pharmacies, which in my mind, and I'm very biased, I'm not old, but I'm a prior. A long time ago, I was a community pharmacist. And I mean, I know that environment, and I think there is a possibility of really this trusted environment for some patients. So it's not for everyone. So what I would like to move forward, and something we're exploring with the California Department of Public Health, is actually developing collaborative practice protocols between community pharmacies and PCPs that are in the community. So not necessarily in large health systems, not inpatient, but really community-based effort. It's not much in the literature on this. I'll give you one slide in a second. I've got a few things from some experiences and challenges I've faced with these collaborative practice protocols that I'll tell you about in one slide. And then I want to turn it over to you. I want to see what you guys think, and then we'll have a little discussion about that. So first, they're from the literature, which you would always go to first. There just are a very limited number of studies looking at community PCPs and community pharmacies under a collaborative practice protocol. The other thing in the studies, a couple of studies that sort of exist, there's very little information about how did you implement that? What really was covered in the collaborative practice protocol? How did you communicate? What about the electronic health records? How this is done. There's very little information on this. The key elements seem to be, as they are in anything, which populations do you target? It's not for everyone. The scope of the collaborative practice protocol and that agreement is very important. Pharmacist credentials. Pharmacists need to be trained in certain areas. Everyone needs to have the trust that the pharmacist is trained and that they're going to be working in collaboration very closely with that PCP. Everybody needs to feel that and do that. And then just integration between organizations. The IT, just think about that a moment. How much trouble do we have within our own organizations? I can't even get my PowerPoint to work now. It's like the IT is so big. But when you go across organizations, it's even larger hurdle. And the processes and communications. Certainly those are key to making something like this work, because we're talking about, envision this, we're talking about multiple community pharmacies with multiple pharmacists in them, working with, under collaborative practice protocols, multiple PCPs out there in multiple practices. So it's a very multifactorial thing. So I can tell you from the experiences I have, and I know that these two speakers have had similar kind of experiences, and maybe they've solved them, we'll hear about this later. Just think about this, the scope of the collaborative practice protocol. Is it just hypertension meds only? Okay, well if I'm the pharmacist, I'm seeing the patient, can I do anything with the lipids? What about diabetes? Are those included? Multiple physicians and sites. Is it one practice and the collaborative practice protocol is with the practice? Or is it with the individual physicians and the site? Which patients? That sounds easy. We want patients that are uncontrolled hypertension. Somebody asked me this question, how long have they been uncontrolled? How do we define that? And what goals are we going to have? Very specifically. So we define that. How do we identify them? Where are they? They're in the electronic health record, probably. Okay, we'll mine that data. Is Is that data up to date? No. And the blood pressure value that's in there. It's all of these thoughts. Pharmacist credentials, yes, you need to be trained, but now we have choices. We have advanced pharmacist practice, pharmacists that are APPs. Does it need to be an advanced pharmacist? Is there certain specific training that needs to be undertaken? Access to the electronic medical record. That sounds easy. And it's like, oh, we have an electronic medical record, the Holy Grail. Oh, we have an electronic medical record, we got a lot of data. How do we access it? Credentialing and privileging. If I'm in the community pharmacy and I'm the pharmacist and I want to come to your, I have a collaborative practice with you, can I get into your electronic health record? How do I have to, I bet I have to be credentialed in your system. I have to have privileging. I have to go through all of this thing that people don't even know who I am in your organization. How about my staff? How about people that are making appointments? You know, or my pharmacy techs? They need to be credentialed somehow in your system. Can I access this remotely? Do I have to be on your site to access the data in your electronic health record? Once I get all that figured out, how am I going to communicate with you? What do you want? Where do you want my note to be? Do we have a note template so you're going to understand it? Are you going to be flagged every time I see your patient? I kind of hope not, because that's just kind of putting more effort and more work on you. You have to figure that out. Communication, just between everybody, knowing that, think about this again, community pharmacists helping you take care of your patients in a community-based PCP practice. What about the people that are in your practice? They need to know what's going on. Who's this pharmacist? Why are they calling them? So those are the things that I've run across in some of our work. I know there are many more kinds of things, but these are barriers. I think there are also things we can talk about to facilitate to get over those barriers too. So here comes your turn. On your tables, there's a piece of paper that I don't have a copy of, and we've got a picture of this little pharmacist, and here's a patient, here's a physician. If you would take 4 or 5 minutes, and I want to interrupt you, and just jot down your thoughts.
If there are some extras, if
I have
you
it.
hold up your hand if you don't have one and you need one.
Yeah, there should be plenty to go around. Take 4 or 5 minutes, just jot down your thoughts on the facilitators, barriers. I'm sorry, I didn't get around. Anybody else? And then we'll share some ideas.
Do people still need them?
Does anybody else need one?
We need extra pencils.
Yeah.
Yeah.
about 30 more seconds, and then I'll share some ideas. Okay, so I gave you and went through this sort of list of barriers already. Did anybody come up with something sort of different as a list of barriers? Or a barrier that you see to implementing hypertension protocols beyond the things that, yes,
Money.
money, okay? Money on both sides, really, for the whole thing, to overcome a lot of these.
All of them.
Right, okay,
I
yes,
think developing a good level of physician buy-in to the process, which patients, all my patients, managed care only, what does that look like? When you talk about decreasing office visits, that's fine if you talk about a managed care population. Might not be such a popular thing if you talk about fee-for-service patients.
Right.
You gotta keep the lights on somehow.
yes,
So I think that's what we're wrestling, we just finished that process, we called our CPA, and it's getting buy-in, what does this mean to me as a physician, to my practice?
right,
So kind of along that line, we thought, well, we're going to be able to demonstrate some wins somewhere along the line. So considering maybe a small pilot, and say,
okay,
here's how it actually works, and let people kind of touch and feel it a little bit.
right. Because I think that's incredibly important, and you're saying kind of the same thing, is that what's in it for the physician? You know, and it may be money that needs to, one way or the other, money has to come in to this, but what is the motivation? They've got to be aligned.
So the greatest motivation that we've heard from our physicians is once they add a pharmacist to their care team, their workload declines and they can focus on more complicated topics that are more interesting.
That is true.
Yes,
When we're talking about community physicians, is that excluding, you go to Dignity Health, building not too far from here, at a primary care appointment, you can go downstairs and go to the pharmacy where a lot of people go. Is that a community pharmacy? Because that seems like an easier place to start with, same record, same alignment.
that's a good point. That is a community pharmacy, yes. I would challenge us the more difficult, because they are in the same, and they have all the shared data. The more difficult case is those that are not necessarily linked, but that could really be a great place to do more, to maybe work out some of these issues.
Right, I think kind of getting that started before you go off to the Wrigley-Bel-Air, which is really community, quite removed from that. But just, those are really daunting, just to get the data flows, and I'm not saying it'd be easy within Dignity or Sutter or UC Davis or Contra Costa Regional Medical Center, but easier.
Yes.
So just something to think about is using, I work at Kaiser and we don't use pharmacists for any of this, but they do population care management for patients with diabetes and cardiovascular disease, but it really is PCP's job to manage blood pressure. But we offer free, easy access blood pressure checks at all of our clinical sites. No co-pays. You can just walk in without an appointment and get your blood pressure checked at any Kaiser site. We have stations staffed by medical assistants that get sent to the chart. Or they can even come to our offices and have free blood pressure checks with the medical assistant. The doctor can make an on-the-spot quick adjustment. We don't charge for it. But just to make it free, easy,
Right.
open access. And we've tried using pharmacists in the past to do some of this. We didn't find it to be cost effective. It was more cost effective and the patients received it better when it came from the doctor. So just food for thought.
Right, and I will, this is my personal belief, because my research is pharmacoeconomics, and it's my personal belief, is that if you're just using a pharmacist to remind patients to take their medicine, to take their blood pressure, it's a waste of money. Yeah, That's why I think this collaborative practice protocol is key. They've got to be able to make the changes in the medications, and that's where you see the big differences. Otherwise, someone else should be doing this. Bob?
Compatible software. We found recently an environmental scan of Sacramento, 17 different softwares. So it's very, very difficult for communication.
I can see that. So. Okay, in the interest of time, I'm moving to one more barrier.
Just one more, just
Okay.
fundamental, we talk about food deserts and probably got pill deserts too, lack of proximity to these kinds of facilities.
Exactly. Yeah, okay. I haven't heard that before. Exactly. Okay. Facilitators. Anybody can think of facilitators for, I didn't have those on here. For either creating these protocols, practices, or implementing? Yes.
I worked in a community pharmacy where we had this in New Mexico, and it worked really well. We collaborated with, we were their 340B pharmacy for one of the 340B clinics. These underserved patients have a really hard time accessing care in general, and it worked really well in our situation there. And then in Ohio, I also worked in a similar situation in a community, I didn't work in that community pharmacy, but I had fellow colleagues working in this pharmacy where they worked collaboratively with the Minute clinics, and it also works really well in that setting as well.
The 340B issue comes up a good bit as being a good population and also maybe a funding mechanism for the savings from the 340B is often brought up. So. Facilitators, in our last minute or so here. Yeah.
So I think you need buy-in from the insurer who's paying for it, be it Medi-Cal, be it the private insurer or the supplemental, because they have access to all of the things. And if the insurer comes out and says, we're sponsoring this program, they can send out an email tomorrow to those individuals saying and explaining what the program is. And at least if the insurer is proposing it as a well-being or healthy, alternative, then you're more likely to get buy-in by the patient because it's their known insurer.
Okay. Yes, the insurer, they buy in from us.
Yeah, I would say also just from a logistical standpoint, once you get all the T's crossed and the I's dotted, you have to have a good quality project manager who's familiar with rolling out a multi-layered